Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Saad, and on behalf of PSA, it's my pleasure to welcome you all again to the PSA online lecture series on the cardiothoracic anesthesia. So basically, this academic initiative comprises of 12 structured online lectures, which mainly focus on the evidence-based practices and recent guidelines and updates in anesthesia, intensive care, and pain management. So basically, today marks the 13th last lecture of this series, and the topic for today's presentation is ECMO for pulmonary and cardiac support. So it's an honor for me to welcome our esteemed speaker, Professor Brigadier Fakhar Fayaz. He's a professor of anesthesia and senior consultant cardiac anesthetics at AFIC, Rawalpindi. Also, he's a vice president of Pakistan Society of Echocardiography and faculty member of American Heart Association. So we are grateful for him for joining us today and sharing his expertise. So before starting the presentation, there are some general instructions for the participants to please keep your microphones be muted and switch off your videos during the lecture. And if you have any questions, you can share it in the chat box either during the lecture or at the end. And after the completion of presentation, please fill out the feedback form. I will share it on the link in the chat box. Thank you. So over to you, sir.
Thank you very much. Thank you, Dr. Saad. Assalamu alaikum, everyone. And first of all, I would like to thank Pakistan Society of Anesthesiology, Karachi chapter, for inviting me to deliver a talk on this topic. Especially Dr. Asma Abdul Sattar, who invited and who is the backbone of this, as far as I know, of this program. And really, hats off to you guys for arranging such a, national forum and delivering lectures and to the juniors and to the peers as well. So thanks a lot once again. And so the topic is ECMO. When your heart is not, able to pump the blood, and the lungs, they are not oxygenating the blood properly despite the maximal support. So we are left with only one option for selected patients, and that is the extracorporeal membrane oxygenation. And that's the topic of the talk today. And in the next 40 minutes, I will be quickly going through what ECMO is and, how to, what are the main indications, how to initiate it, how to manage it, how to do troubleshooting. And then afterwards, how to wean the patient off from the ECMO or shift to the other supports like the ventricular assist devices or to the, bridge to transplant. If it is a bridge to transplant patient, then, the transplantation, etc. So let's start. I don't have any disclosures to make. This is a purely academic thing, and which I'm going to present, no funding at all. So what are the learning objectives of today? First is understand the principles, components, and physiological effects of extracorporeal membrane oxygenation. Second is identify the appropriate indications, contraindications of both the modalities like VA and VV ECMO, and then describe the basic cannulation strategies and the roles of multidisciplinary ECMO team. And fourth one is apply evidence-based principles for ECMO initiation, daily management, anticoagulation, troubleshooting, and weaning, as I've already mentioned. Recognize common ECMO-related complications and institute timely interventions to improve patient outcomes. So what is ECMO basically? So ECMO is basically, it's extracorporeal membrane oxygenation, a temporary extracorporeal life support system that provides the respiratory and or circulatory support. So it will support the lungs or it will support the heart or both simultaneously. Then, in patients with severe but potentially reversible cardiac pulmonary failure when conventional therapy is insufficient. So this is very important point. Every patient cannot be placed on ECMO. So there should be a potentially reversible cardiac or pulmonary failure where we are expecting some kind of recovery, and we expect that the patient either will have the organ transplanted or will, his own organ will recover. So the basic components of the ECMO circuit, if we see there's a drainage cannula which is coming from, draining the heart, and then it's going to the pump, and then there's a drain of the, of whole equipment which is called console. So the pump pumps the blood to the oxygenator, and oxygenator is attached with a blender, and there is a heat exchanger as well here. And what it does is that it removes the oxygen, it removes the carbon dioxide, and it adds up the oxygen, and it maintains the temperature, and then it pushes the blood into the arterial side. So these are the basic 5 components of the ECMO. And as we already mentioned, that the main function is to draw the blood from the venous side, oxygenate it, and remove the carbon dioxide, and then return it towards the arterial side. And if we are using only VV ECMO, then the return cannula will be attached into the venous side, and then but it will be doing the same function, adding the oxygen and removing the carbon dioxide. So what are the physiological effects? So as we know that there are 2 types, veno-arterial extracorporeal membrane oxygenation and veno-venous extracorporeal membrane oxygenation. So the basic difference is that the veno-arterial will support mainly the heart, but the lungs as well as a complementary thing, and it will maintain the cardiac output, mean arterial pressure, coronary perfusion, systemic perfusion, and oxygen delivery. The VV ECMO part, which is the veno-venous, where we are taking out the blood from the venous side and we are pushing it to the venous side again, it only supports the lungs. And by oxygenating the blood, by removing the carbon dioxide, and basically it will protect the lungs, when we are struggling with type 2 respiratory failure in patients in ICUs, and we are trying to push the lungs to their maximum capacity through ventilators. So the chances of, ventilator-associated lung injury, they are very high. And actually, we're not doing any benefit, but we are just trying to maintain the homeostasis of the body. And but we are causing injury to the lungs. So what ECMO does is that it doesn't push the lungs to their maximum, and it gives them rest. And in the meantime, the time which we buy during that period of time, the heart or the lung, they will recover. Or if they don't recover and the patient is, transplant candidate, then we can go for the heart transplant or the lung transplantation. Or as a destination therapy, we can do the ventricular assist device implantation, etc. But there are certain criteria for all that. So which I will not be discussing this. It's not in the domain of this lecture. So why we want the patient, to why we want to put the patient on the ECMO when it is there are cost issues, and then the recovery issues, and then we say the selected patient should be placed on it, and there should be some kind of hope of recovery. So it is basically on the based on the 2 trials. One is the Caesar trial, and the other one is the Eolia trial, on which where we have seen that not many patients who survived after having this much diseased lungs or the heart. So, but if we look at this table, the maximum benefit is in the neonatal age group, where 73% of the patients who were placed on the VV ECMO, they got transferred out of the ICU, or they got discharged. It's a mix, not all of them went home, but those who got discharged from the ICU, they were also included in the study. So, but if we see in the next group is the pediatric patients, who also have the maximum. But on the adult side, the figures are not that bad. If we look at on the adult side, the VV ECMO results are 59%, which is pretty good. And if we look at the VA ECMO side, where we provide the support to the heart and the lungs both, the 44% almost, if we say that 50% or nearly 50% of the patients were saved by putting the patient on ECMO. And believe you me, when you don't have any other thing and the patient is dying, it's a big hope. So how, uh, so see this concept of ECMO or the extracorporeal life support, basically it initiated in 1950s, where when this hardening machine got popularized, and since then the people were trying to put the patients on long-term on long-term oxygen, this heart and lung support, but they were unable to do it because there were a lot many complications. The initial oxygenators, they were not that good. But since now we have got advancement in technology, so we have polymethyl pentene fiber, which is basically a long-term fiber which can sustain this flow for so many days. And they basically, this oxygenator is uh, that consists of uh, hollow fiber. These are the tubules, basically, if you look at here, and through these tubules, the gas, which is oxygen, is flowing, and outside these tubules is the blood. So it's again, the same mechanism where, like dialysis, but in dialysis, we are playing with the fluid, but here we are playing with the oxygenation and the with oxygen and carbon dioxide. So what does this oxygenator do is that it removes the carbon dioxide and it adds up the CO2. And remember, the amount of oxygen will added to the blood will be directly proportional to the inspired fraction of the oxygen, and the amount of CO2 removed will be directly proportional to the sweep gas flow. So sweep gas flow is basically the liters per minute of oxygen which is flowing through this oxygenator and going entering from one side and going out from the other side. So this is how this oxygenator works. So what is the patient selection criteria for ECMO? So we cannot place every patient on ECMO because of the cost issues, and there are so many other issues attached with it. So the first thing is that patient is the refractory is the refractory cardiorespiratory failure, and then the next question is, has maximal conventional therapy failed? If the answer is yes, then we will look for whether we require cardiac support. Then we could, if we require a cardiac support, then we will go for VA ECMO, and if we require a respiratory support, then we will go for VV ECMO. So if we require combined support, then cardiorespiratory, if there's cardiorespiratory failure, then just the VA ECMO is the answer. So the first thing, disease potentially should be reversible. Optimal conventional therapy phase. So these are the 5 questions which we need to ask ourselves whenever we are making decision to put the patient on ECMO. So which organ is failing, heart or lungs? Does the patient meet VA or VV ECMO criteria? And will ECMO provide a realistic bridge to recovery or definitive therapy? So these are the 5 questions which we need to answer before putting the patient on ECMO. So common indications for the veno arterial ECMO is permeabilism, myocardial infarction, myocarditis. But as far as ourselves are concerned, in FSC, we are putting the patients for, most of the time we are putting them due to post-cardiotomy, cardiac failure. But post-heart transplant, we have seen, when I was working abroad, we have seen patients going on ECMO when they had heart transplant, and initially the organ was not working. Acute on chronic heart failure, cardiac arrest, ARDS, refractory ventricular arrhythmias, cardiac trauma, acute anaphylaxis, cardiac support for percutaneous cardiac procedures. So these are the new indications, which have come up in the last few years, where we now support few high-risk procedures with the backup support of ECMO. So what are the contraindications of the veno-arterial ECMO? So the absolute contraindication is the disseminated malignancy and advanced age. Although they have not defined that advanced age, but in UK, usually they have if they have not increased the age, but previously they used to put the patients if they are below the age of 60. But as far as the literature is concerned, they have not defined any age group, but advanced age we can have our own protocol. So if the patients have severe brain injury, we don't put them on ECMO. And if there is an unwitnessed arrest, we don't know how much the downtime is, so we usually don't do the ECMOs on them. So relative contraindication, because it's going to be difficult to manage if the patient is having concomitant aortic regurgitation or aortic dissection. So it's sort of a relative contraindication where we will not be able to manage the flows and the heart will be getting distended. So, and then as we know that we will be requiring anticoagulation throughout the procedure. So if there is contraindication to the anticoagulation, then we will not be able to put the patient on the ECMO support. So as far as the VV ECMO is concerned, the indications are severe ARDS, which is the most common indication to put the patient on ECMO as far as the VV ECMO is concerned. If the patient is having refractory hypoxemia despite optimal ventilation, and if the patient is hypercapnic, the COPD patients, although there are other few devices available like ILCOR, etc., for only CO2 removal, but ECMO is a better support for those kind of patients. So if the patient is having is a lung transplant candidate, then as a bridge to lung transplant, we can use it. Although in Pakistan we don't have any lung transplant program or the heart transplant program as yet as we are speaking today. So severe asthma patients, they can be placed on ECMO when they are having persistent status systematicus. So diffuse alveolar hemorrhages, but they are selected cases, severe inhalation injuries, the burn injury patients, there's limited data on it. But these are the upcoming sort of indications. So absolute contraindication is irreversible lung disease in a patient who is not a lung transplant candidate. Relatively, if the mechanical ventilation was done more than 7 days with very high settings, so then there are very less chances of recovery of those lungs. Major CNS bleeding, malignancy, chronic immunosuppression, advanced age, limited vascular access. Basically, these relative contraindications are taken from the EOLIA trial, and these were basically the contraindication. But mind you, these are the latest guidelines. They have included these relative contraindications from the EOLIA trial. Actually, there is an extra corporeal life support organization by the name of ELSO who publishes the guidelines for ECMO and all the extracorporeal life supports. So these are from ELSO guidelines. So for patient selection criteria for VA ECMO, ideal candidates, as I've already mentioned, with reversible cardiac disease, the disease who have failure to conventional therapy, there's no neurological injury, acceptable long-term prognosis, or if they are candidates for left ventricular assist devices or transplantation. But, we should avoid if they are irreversible multi-organ failure. So that means, जब भी हमें डालना है ECMO के ऊपर, so we should not be taking or pushing the organs to their limits, and we should decide early. So if we decide on day 10 and we have already, damaged the lungs, then probably there's no fun of putting the patient on ECMO. There's severe irreversible, if there is severe irreversible neurological injury or unsalvageable cardiac disease without destination therapy, so probably there's no fun of putting the patient on ECMO. So VV ECMO, as far as VV ECMO is concerned, so again, reversible lung disease, severe hypoxemia or hypercapnia, lung transplant candidate if irreversible. So irreversible lung disease in a patient who is not a lung transplant candidate we should avoid VV ECMO. See, when we talk about the ECMO or putting the patient on ECMO, it has got a lot of financial burden. It's not only financial burden, but it causes burden on the human resource as well. Your ICU bed gets committed. Usually we place one nurse per patient, but for ECMO patient, you need to have two nurses in each shift for one patient. So it has got, a lot many implications. So it's not that easy to decide about it. So coming to the ECMO cannulation strategies, the ECMO and the ECMO team. So basic principles of the ECMO cannulation is that, we should be placing adequate sized venous drainage cannulas so that we should not be struggling with the venous drainage flow, because that's one of the problems which we face quite often when the patient is placed on the ECMO. Then efficient oxygenated blood return, minimize recirculation, VV ECMO, that's the problem with the VV ECMO only. So avoid limb ischemia and vascular complications, ultrasound and or echo cardiographic guidance whenever possible. So ultrasound here has got, a pivotal role in placing the cannulas. So VECMO cannulation strategies. So when we talk about the veno-arterial ECMO, so we have got two basically strategies. One is peripheral and the other one is central. Peripheral is from femoral vein to the femoral artery, and it is done percutaneously, and it's rapid bedside. It's a rapid bedside procedure which we can do it, but usually we take the patient to the theater for risk of infection. So, but if we are in a hurry, we can place the patient in ICU as well. So this is easier to initiate, but there is risk of differential hypoxia, which I will be coming at the end, what the differential hypoxia is. So the next is central VA ECMO is from the right atrium to the right atrium. We will drain the blood from the right atrium and we will put the blood into the ascending aorta. And this is done basically through the sternotomy, and it's a surgical procedure, and it's usually done in operating room. It's common after cardiac surgery, post, as I've already told you that we are mainly doing it for the post-cardiotomy and cardiac failure. So it's got better integrated aortic flow. It requires sternotomy. So these are again, just to make you understand, in central VA ECMO, we are draining blood from the right atrium, going to the pump, from the pump to the oxygenator, and after oxygenation and pumping, it goes directly to the ascending aorta. And when we talk about the peripheral VA ECMO cannulation side, so one cannula is draining from the IVC and again going to the pump, oxygenator, and then it is returned to the femoral artery site. So these are basically for the VA ECMO, but when we talk about the VV ECMO cannulation strategies, so mainly there are three strategies. So most commonly we do the femorojugular one. So basically, if you look at the first A is a drainage cannula and it stays in the IVC, and it's again, after going through the same process, the blood is returned into the right atrium so that it can directly go from the right atrium to the tricuspid valve and to the permeable circulation and to the patient. Because we are draining from the same site, so there may be, recirculation, sort of hypoxemia. So when the other strategy, other alternative is femorofemoral, and when femorofemoral, we place one drainage cannula in one femoral vein, and which is, placed in the IVC, and the return cannula is placed into the right atrium, and usually from the other side of from the other femoral artery, but that basically goes into the right atrium for the return cannula. And then we have got, wonderful Avalon cannula, which has got two stages, and it has got, one orifice which is for the return blood, and that opens to the right atrium, and the other lumens are basically placed in the IVC. So this is basically inserted from the right IJV, and it is also placed under echo guidance. And it has got the, advantage that the patient can mobilize. So imaging has got a pivotal role in it, whether you are using ultrasound, fluoroscopy, transesophageal echo or transcystic echo. So we usually do in our setup, we under transesophageal echo guidance. So we show the surgeon or the operator that there is a wire. This is basically mid-esophageal bicable view, and this is the left atrium, this is the right atrium, and this is the intra-atrial septum, and this is the wire which is inside the right atrium, and then this is the cannula. And we can exactly tell the operator that where they should place or where they should end up placing the cannula and how many centimeters they should withdraw, etc., under transesophageal guidance. So it's such a wonderful, sort of under vision process. So what are the heroes of this team? The intensivist is the team leader, patient selection and daily management is his responsibility. Cardiac surgeon plays a pivotal role of cannulating and decannulation. Cardiac anesthetist is providing the backup and the imaging facilities. And then the man who basically deals with the console is perfusionist, the ECMO circuit management and all that, making and all the connections of the circuitry is the responsibility of the perfusionist, and then flow changes and if we need to change oxygenator, then it's the responsibility of the perfusionist. And let me tell you, the most important member of this team is the ICU nurse. So they basically make the difference. So they are holding the fort 24/7, and 90%, I must say, the success relies on the expertise and the competence of ICU nurses. And then definitely the respiratory therapists, they have got the role in ventilator optimization, but here we usually do ourselves. So physiotherapists, yes, in early mobilization and rehab, and then there is a big role of the pharmacists in advising anticoagulation and drug dosing, because there lot many drugs will lose their efficacy, and lot many drugs will have their efficacy enhanced when we place the patient on the ECMO support. So immediate post-cannulation care, we need to see the cannula positions confirmed. There is adequate ECMO blood flow, and then oxygenation, is it improving or not? Mean arterial pressure, is it adequate or not? Anticoagulation initiated. Distal limb perfusion is very, very important, especially in the VA ECMO. And the peripheral when we are using the peripheral VA ECMO and we are using the femoral artery cannula, that can totally block the circulation to the distal part of the limb, and we usually place distal perfusion cannula just to save the limb. And then we definitely do some adjustments to the ventilator, because we don't want to push the ventilators to their maximum, and we just want to relax the lungs, but we don't want to lay them lazy. हम नहीं चाहते कि वो बिल्कुल हड़ा आराम हो जाए जब तक ECMO पे मरीज है. तो इसलिए वेंटिलेटर की एडजस्टमेंट में इस तरह करते हैं कि मिनिमम प्रेशर जो है दैट शुड बी ऑन द लंग्स. तो उसके अपने अपने क्राइटेरियाज हैं. देन देयर इज लैब मॉनिटरिंग व्हिच वी आर डूइंग regularly. So initially, if we talk about the initial settings, so the circuit flow is usually again, based on the cardiac index, and that is if we try to keep it more than 2 liters per minute per meter square. So exactly this is the adequate cardiac index which we are trying, and we try to achieve it. If it is more than 2, we are happy. If it is more than 2.5, we are very happy. So the sweep gas flow rate, usually, as I've already mentioned, that the CO2 removal will be directly proportional to the sweep gas rate. So if you increase the sweep gas rate, there will be more removal of the CO2 from the blood. So we try to adjust it initially according to the cardiac output in liters per minute. So we try to match them, and then we do the ABGs, and if we are happy with the carbon dioxide levels, which we try to keep around 35 to 45 millimeter of mercury, then we continue with the same. Otherwise, we try to tweak with the gas flow rate, the sweep rate. Then, again, the same targets which we all know, that the arterial pH, we want 7.35 to 7.45, mean arterial pressure more than 60, but we don't want to go beyond 90 because already the patient is so much anticoagulated. If we increase the mean arterial pressure beyond 90, then there are, the chances of hemorrhage, intracranial hemorrhage, they will be increased. So we want to keep the hematocrit around 30 to 40% or the hemoglobin above 6. Then we target the anticoagulation by monitoring the APTT. The target is more than 2, but in our setup, we basically target the ACT, which we want to keep around 180 to 220 is our target. And then we want to keep the platelet count more than 100,000 because wherever there is anticoagulation, there is risk of bleeding. So we don't want platelet count to be short less than 100,000. So initial ECMO management in the first hour, I've already mentioned, we look for the hemodynamics and we go for the gas exchange and we look at the circuits. So as far as the daily management on ECMO is concerned, we look the patient and we look at the circuit. So when we look at the patient, what are the most important parameters are the mean arterial pressure, the cardiac output, the lactate level. So lactate is basically, telling you the perfusion of the patient, and if it is rising, it's not a good news. And then mixed venous oxygen saturations, which this ECMO machine directly tells you minute by minute, and we can have a good idea that the tissues, whether they are suffering or not. So the respiratory ventilator settings, we definitely don't want to push the lungs during that when we want them to rest. And chest X-ray is one of the basic modalities which we do every day, and whenever we think maybe sometimes twice or 3 times, and then we monitor the gas exchange. As far as the laboratory is concerned, complete blood count, ABGs, coagulation, renal function, liver function, they are all important. But let me tell you, infection is the biggest enemy of the ECMO patient. So basically the prevention is the main thing which we need to focus. But whenever we have infective markers, we do daily infective markers, but whenever we see that the patient is, the infective markers, they are going high, we do cultures and we change the antibiotics, and especially the line-related infections, they are common in patients. And let me tell you one thing, because we are maintaining the temperature, and there is a thermostat in the ECMO machine. If we have set the the temperature at 36, that machine will keep the patient's temperature maintained at 36. So fever, we may not have fever when the patient is on ECMO machine, unless we have not set the right temperature on the machine. So as far as anticoagulation is concerned, we are all familiar with heparin, and it's commonly used because it has got a reversal agent, which is protamine, but it causes thrombocytopenia. And when we have thrombocytopenia with heparin, which we call heparin-induced thrombocytopenia, then we need to go for the alternatives, and the alternative is bivalirudin or ergotroban. Bivalirudin and ergotroban, they are not available in Pakistan as far as I know. We only have heparin, and they don't have any reversal agents. We used to have it bivalirudin. We have the experience of using it in UK, but it is pretty expensive drug, and that's why it's not available. I'm not aware that whether it's available in Karachi or not, but it's not available in Rawalpindi and Islamabad, or at least in our setup. So the monitoring which we do is the ACT, which I've already told you that we do it in our setup. APTT, because it's not a bedside thing to do, but we do it daily, and whenever we have a bleeding patient, then we do it. Anti-10A is not available. Rotem and TEG only done when we have a patient who is bleeding and we are unable to control it and we don't know what the reason is. So and then we do the TEG. Otherwise, we don't do the TEG, for monitoring purpose. So for monitoring purpose, we only do the ACT. So a few words about the mechanism. We all know the mechanism of heparin. Heparin requires antithrombin 3 for its activation. If the antithrombin 3 is not available, the heparin will not work and the ACT will not rise, and there is a risk of coagulation or the clots inside the circuit. So in that case, what we do is we transfuse FFPs first, and then we do give the heparin. So we all know that heparin is that directly affects the factor 10A and then prothrombin, and then it inhibits the thrombin, and the thrombin will not let the fibrinogen to convert into fibrin. Then there are direct thrombin inhibitors like bivalirudin and ergotroban. They directly inhibit the thrombin, bypassing the previous steps, and the thrombin will not, when it's inactivated, it will not let the fibrinogen to convert into fibrin. So what are the basically targets which we want? Just remember this thing, the target is 180 to 220, and we usually try to keep the ACT around 200. So memorize the magic number of 200. And for APTT, memorize, more than twice the normal. So, but as a factor 10A, I don't have any experience of monitoring it. And then tag our time, we can keep it more than 20-25, but we have not seen it even in UK to keep it, use it as a monitor. There we also used to use only ACT. So factors affecting anticoagulation levels. So if we are keeping the circuit flow rate at a low, then we need to anticoagulate at a higher. We will have to go a higher level anticoagulation. So we may need to increase the ACT. If the platelet count is less than 100, there is a big risk of platelet bleeding. So bleeding, if there is active hemorrhage, may require even discontinuation of the anticoagulation. See, we can't bleed the patient to death. So we can stop anticoagulation for a while. We can secure the bleeding, and then we can restart the anticoagulation. Hypothermia affects the platelet function, and there's more risk of bleeding. Antiplatelet, definitely more risk of bleeding. Thrombophilic conditions, if we have like cancer, so the patient anticoagulation, we need to increase it. Heparin-induced thrombocytopenia, then we need to, require the novel drugs like I've already mentioned, the bivalirudin or the ergotroban. So now coming to the, main problems which we face while managing the ECMO. So there is, if there is low ECMO flow, the venous line will start chattering. Some people call it dancing. So it's an indication that the patient is either hypovolemic or the cannula is malpositioned and it's not draining. And the ECMO pump is basically struggling to get the required flows. So if that thing happens, so we need to do the volume assessment or we need to reposition the cannulas. We usually give fluid at that time or the blood if the patient is having anemia. Then we give blood and the problem is solved. But if it is occurring again and again, then we need to see, whether our cannulas, they are rightly placed or not. So persistent hypoxemia, especially in VV ECMO, there is the recirculation may happen, especially if the drainage cannula and the returning cannula, if they are very close to each other, then this recirculation phenomena will happen, and actually this will be, circulating same blood through, and there will be deoxygenated blood going to the left side of the heart. So, or the other thing which can happen is the oxygenator dysfunction. We need to see the oxygenator very carefully. We need to do the ABGs pre and post oxygenator. We need to see the membrane pressure, which we call the TMP. If it is rising, that's the indication, that there may be clots sitting in the oxygenator, and the oxygenator needs to be replaced. So if there is hypertension, patient may be having bleeding, tamponade, or cardiac dysfunction. So identify the cause and optimize the support. If there is bleeding, then we need to see whether we are having excessive anticoagulation or is it a surgical bleed. So accordingly, we will manage it. Limb ischemia is, is a problem when we are using femoral or the peripheral VA ECMO or VV ECMO. it's peripheral VA ECMO. So that's the thing, which can be solved by putting in a distal perfusion catheter. And then if there is hemolysis, then we need to see whether we are having a very high pump speed to achieve our desired cardiac output, because on the machine we actually set the pump speed, and with the help of that pump speed, the flow increases. Or the circuit may be having thrombosis, and then so inspect the circuit, consider oxygenator exchange. Now coming how to get the patient back or remove from the ECMO to the native circulation, or to place the patient to the other support. So both VA and VV ECMO have their set criteria for weaning. So as far as the VA ECMO is concerned, the recovery of ventricular function under echo guidance, that is basically required. If the heart has not recovered, then there's no fun of giving any kind of trial. If there is adequate pulsatility of which we can see by opening and closing of the aortic valve through transesophageal echo or from the transathecal echo. So if the inotropic supports, they have really come down, and we are persistently maintaining the mean arterial pressure above 60, and there is gradual reduction in. So what we do is that, we gradually reduce the ECMO flow, and we see whether heart is trying to cope up with the extra blood which is coming now to the left ventricle, and is it able to handle it or not. And then we reduce the flow to minimum to 1 liter, and then we try to assess through the echo and the other parameters of cardiac output monitoring that will help us whether we will be able to remove the V ECMO or not. So weaning from the VV ECMO, native lungs, so prerequisite is that native lungs, they are able to handle the gas exchange around 50 to 80%, improving lung compliance, and chest radiograph is an indication. Then stable oxygenation and ventilation is another indication that, the patient is ready to be weaned off. So the ventilator targets are that FiO2 is less than 50%, and the patient is having adequate PO2 of 60 to 80 millimeter of mercury. The peak inspiratory pressures, they remain below 25 to 30, and the respiratory rate is around 10 to 16 breaths per minute. And by acceptable PaO2, we mean 60 to 80 millimeter of mercury. PaO2 and PSO2 is around 35 to 45. So how we do it, that we basically here we reduce the gas flow, the sweep gas flow, and we just turn it off, and then we see whether the lungs are able to oxygenate it or not. Or if we don't have the blender, then we can reduce the ECMO flow in VV ECMO as well. But there is risk of clot formation in the circuit. So this is a bit risky procedure, but mainly we do it by reducing the sweep gas flow rate. Now, coming to the complications of the ECMO, there are basically it's four-pronged complications. There are few patient-related, and there are few circuit-related problems. The mechanical problems, they are basically mainly circuit-related, cannula malposition, pump failure, or there may be clot in oxygen, or if there are, the circuit is not tightly bound to the connection, then there may be risk of air embolism. Then thrombotic DVT can happen, stroke, circuit thrombosis, and there are bleeding problems, hemorrhage from cannulation site. And whenever, we are losing hemoglobin and we don't have any visible site, we always think of the gastrointestinal tract, that the patient may be bleeding in the gastrointestinal tract. So, but infection bleed, that may happen. Then I've already told you that the infection is the biggest enemy of the ECMO patient. Now coming to one unique complication which happens only with the peripheral VA ECMO. This is called North-South syndrome or the Harlequin syndrome. Basically, what happens is that if the heart has recovered and the lungs, they have not recovered, so the heart starts ejection, and then there is amount of blood which is passing through the heart, going through the diseased lungs, and we know that the lungs, they have not recovered. So what will happen is that the upper part of the body will be cyanosed, and the lower part of the body, as it will be, perfused by the ECMO circuit through the peripheral cannulation site. So the peripheral part, the lower body will be pink, and the upper body will be cyanosed. So this is called the north-south syndrome, that basically it shows that heart has recovered, but the lungs, they have not recovered. So what to do? We can convert to this. One answer is that try to increase the flow from the ECMO, or we can do is that we can start these VA ECMO, or we can shift the drainage, this arterial cannula to somewhere in the ascending aorta. So that will solve the issue. So when should you worry? Well, early recognition is basically the key. Reduce ECMO flow, hypovolemia, cannula malposition, circuit obstruction, rising lactate will indicate inadequate perfusion, persistent hypoxemia, oxygenator will show oxygenator failure, recirculation, VV ECMO, or worsening lung disease, dark blood in return line, oxygenator dysfunction, then high circuit pressure, which I've told you that we monitor the transmembrane pressure, oxygenator clot or obstruction. If the pump starts shattering with dancing movement of the pipes, especially the venous drainage site, then inadequate venous drainage, certain neurological changes may show the stroke, especially the intracranial hemorrhage. So coming to the key take-home messages, there are 5 rules of safe ECMO practice. Anticipate complications before they occur, perform structured bedside assessment every shift, monitor the patient and the ECMO circuit. So हमें दोनों चीजों को देखना है, patient as well as the ECMO circuit, escalate concerns early and involve the multidisciplinary ECMO team. And then early recognition and timely intervention saves life. Okay, so what's the deadly complication of ECMO? As I've mentioned number of complications before. So what do you think? Which one is the deadly complication of ECMO out of these? Do you have any idea? Am I audible? Although it's not the right time to ask a question, as I've almost finished my lecture or my talk. So any complication which you are not able to pick in time is the deadly complication. So all of them, they may fall into that category of the deadly complications if you are unable to pick in time. So the key message is that you should be vigilant when you have placed a patient on ventilator. And remember, the patient on the ECMO. So remember, ECMO is not a cure, it's a bridge. So the outcome depends on vigilant monitoring, prompt recognition of complications, and coordinated multidisciplinary care. Thank you very much. If there are any questions, I'm happy to answer.
Thank you so much, Dr. Fakhar, for an excellent talk. There is one question has been asked by Dr. Shahid Rasool. What's the role of ECMO in sepsis and COVID pandemic? Do you have any experience? Will you please share?
During the COVID, I was in Pakistan, but I did visit the UK during that period of time. And I tell you, all the cardiac ICUs, they were converted into COVID ICUs, and they placed a number of patients on the ECMO, and the results were not bad. So in COVID, they placed the patient on VV ECMO, and the numbers were very promising, and that's why they placed many patients on this VV ECMO. So there are good results, but again, your criteria should be stringent to place the patients on the ECMO.
Yes, absolutely. Any comments or
But in
any
Pakistan we
question
don't
from the
have,
participant?
yeah.
Yes.
But in
Yes.
Pakistan, as in my center, we don't have the experience of putting the patients on. We placed only few, but they did not survive, to be honest.
Okay. Okay. So do you have any comments or from the participant? Any questions? You can share it in the chat box, or you can share it online as well. Any questions or any comments? So meanwhile, I take comment from Dr. Amin Khwaja. Sir, will you please comment regarding all these lectures or regarding this lecture?
Thank you very much. Thank you, PSA. Thank you, Dr. Fakhar, for taking time to present this excellent presentation. The important thing, the take-home message, which I think Dr. Fakhar has also said, decision to put the ECMO timely, because in our centers, our figures are not double, but we have 3 or 4 patients on survive on ECMO. They were planned in the OR. One was with an RV failure, and then we converted to the VV ECMO. So important thing is to put the patients timely on the ECMO. That is very important. Otherwise, it is too late to utilize the facility and equipment. There's no any much benefit. Thank you once again.
Sure, sure, sir. Thank you, sir. Sir, there is one question. Can ECMO increase the left ventricular afterload and causes the LV distension? This is from Dr. Amber Andani.
Yeah, actually, it does not. Yes, it can increase the LV afterload, especially when we are using the peripheral VA ECMO from the femoral side, and the heart is ejecting. Although there is a watershed area where the ECMO flow ends and the heart basically that has got its own flow is coming, and that watershed area, definitely it can increase the afterload. As far as the LV distension is concerned, yes, this can happen. When we increase the flow on the ECMO side, and it will not let the aortic valve to open. So if the aortic valve is not opening, then what will happen is that although we are trying to drain the blood from the right atrium, but we all know that there is certain blood which is not coming to the right atrium, but it's going to the left atrium through other means, especially the lung circulation and all that. So that flow is definitely going to the LA, and then from LA to going to the left ventricle. And if the aortic valve is closed, then LV can distend. And for that thing, what we do is that we place a drainage cannula, an extra drainage cannula from the right superior pulmonary vein, or we can place it directly into the left atrium. But placing it directly into the left atrium has got chances of air embolism. So we try to do it from the right superior pulmonary vein. We place a drain into it, and then we place that drain in, with the ECMO drainage circuit. So this is how we can manage it. And by daily surveillance, when the heart starts ejecting, we try to reduce the flow so that the LV afterload is reduced. It's a very good question. I hope
thank you, sir. Yes.
You guys understood.
Yeah. Thank you so much, sir. So any questions or any comments from the participant, please share it. So I would like to thank Professor Brigadier Fakhar Fayaz for delivering an excellent lecture. So, sir, there is no more questions. All the parts of the ECMO has been you have fully covered. So there is one question in the chat box. What are the indications for ECMO? Indication for ECMO is there BMI. Dr. Hilal Siddiqui.
BMI is body mass index.
I think Dr. Hilal, will you please clarify?
or
Dr. Hilal,
something
will you please clarify?
bone marrow something, maybe. If there is high BMI, then definitely it's going to be difficult to achieve the flow rate. Reason being is that we need just body mass index. So probably he's trying to ask, if there is high
Yes.
BMI, then how we can. Yes, we need to have good drainage cannulas, as I've already told in the basic principles of placing or selecting the cannula. So we need to have good drainage cannulas. So if we are draining good amount of blood, then we will be able to push the good amount of blood inside the on the arterial side, and we'll be able to oxygenate it properly. We have good drainage cannulas. So we need to put in bigger size cannulas, and for that purpose, we usually the femoral artery and the femoral vein, they are not that good for bigger cannulas. So then the only answer is the central cannulation in VA.
Sure. Thank you, sir.
Does the
Sir, there is
site
one
of
more question.
cannulation
Yes,
affect?
yes, yes.
Yeah. Does the site of cannulation affect which artery should be used for arterial blood gas sampling? Yes. So, whenever you are using the peripheral VA ECMO, always remember that we need to put the arterial line on the right radial side. So that's the ideal, because that's the most farthest point from where you can have your arterial sampling done, and that will be basically telling you the whole story. But so we usually try right radial, and as far as then there are multiple sites from where we can have, we usually do the sampling from the pre-oxygenator. We have got a port in it on the ECMO pre-oxygenator blood sampling. We can have ABGs, and then in the post-oxygenator we can do the ABGs. So there are multiple sites from it, but as far as the patient is concerned, we usually do it from the right radial. As Dr. Amber has already mentioned.
Yes. Thank you so much, sir. So now we can conclude this final lecture of this PSA online lecture series. Thank you so much, sir, for delivering an excellent lecture. So before concluding, I would like to express my sincere gratitude as I've been involved in this lecture series, starting from selecting the topics and planning the academic content and moderating all these 13 online lecture series. I would like to thank Dr. Asma and the Pakistan Society of Anesthesiologists for placing their trust in me and providing me this wonderful opportunity. I would also like to thank all the distinguished speakers who generously shared their knowledge and expertise while making this series a valuable learning experience for all our participants. And thank you so much, all the participants, for actively being involved throughout this series. So thank you. Thank you so much. Wish you all the best. Thank you so much, sir.
Thank you.
Please fill out the feedback form.
Thank you,
I
Dr.
shared
Saad,
thank you. Yes, sir. Thank you, sir. Okay. Allah Hafiz.
Thank you. Allah Hafiz. Allah Hafiz, everyone.
Allah Hafiz.
Thank you, sir Amin. Allah Hafiz.